So the classes of drugs we're going to be looking at here, again, we're continuing with drugs to treat pain. Now we're looking at opioid analgesics. So in the previous chapter, we looked at non-opioid pain relief medications and kind of talked about their mechanism. So now we're moving into a different class of pain medications, discussing opioids. So if we just look at what opioids essentially are, so they're natural opiates derived from the poppy plant. We actually have two different types of opioids. So we have endogenous opioids. So endogenous opioids are those that we actually have within our body. So those are naturally occurring ligands that are found actually in the brain. We actually discuss those in therapeutic modalities. We talk about how just through the body's own pain control, the body kind of has its own pain control mechanism, which we look to actually leverage with our physical agents, if you will, and kind of allow the body to produce those to help in reducing pain. Whereas the exogenous opioids, which is what we're going to be focusing on in the discussion here, are your synthetic or semi-synthetic opioids that we take to kind of help in managing pain. Again, they are an effective treatment for non-cancer chronic pain. However, they do kind of come with some drawbacks, and there's been some issues recently as far as misuse and abuse of opioids. So while they are very effective, there have been a lot of issues. So you see here just some of the statistics. So again, these are definitely, drugs that need to be very heavily monitored and only given when absolutely necessary. Fentanyl, which is a very strong opioid, there's been a lot of problems associated with that. You see the number of deaths that have occurred related to fentanyl. So again, they should be prescribed if they can benefit pain and function. And again, we had talked about how, again, for the exogenous opioids, you have synthetic, semi-synthetic. So as we kind of move along with the discussion, we're going to get into some of the different types and kind of how they could possibly use based upon their onset of action. The really important point whenever somebody's going to be given, first of all, you certainly want to make sure that, again, non-opioid options just haven't been working. That has to be the first step. So, and then even when you move to this, again, start with a low potency and build to higher potency opioids. So we'll talk about clinically, this will be kind of discussed with the provider that, and most providers should start with a more low potency opioid. But it's very important that from an athletic training perspective, we're aware that if we do have a patient or somebody that we work with that has been prescribed these, to make sure that they're educated on how they should be taking them, when they should stop taking them, so on and so forth. So again, appropriate use of opioid analgesics, and this is again some of the things that you really have to consider related to these, again, because these are very powerful drugs. Again, needed and effective at times, but sometimes, again, if you just even look in recently, there's been kind of a problem with opioid dependency. So again, they should not be the first routine therapy for chronic pain. So again, we have, particularly for the conditions that we treat, we have our physical agents that could certainly be used. We have non-opioid, whether those be over-the-counter or prescription options to treat pain. But that's where those should be kind of the first line, and then after that, obviously, we would look at the opioid analgesics. You want measurable goals for pain and function should be set. So again, much like everything else we do therapeutic-wise for things, if somebody's going to be prescribed an opioid analgesic, there should be kind of some goals kind of looked at as far as, how we're going to be using those and looking to possibly discontinue these over time. So we want to discuss the risk and benefits, because obviously we want to look at we always want to look at non-opioid options to start. Now, again, some people may need something stronger, and then that's where this would come in. You want to prescribe, ideally, prescribe only immediate release opioids for acute pain, and that's because they're going to just tend to be a little more effective for regarding acute pain. And in any case, again, we always still want to go by the kind of the saying, start low and go slow. So don't prescribe any more that's needed. Okay. Even in the case of an acute situation, don't prescribe more that's needed. See if you can get a benefit with a very low dose of any type of opioid. Do not prescribe extended or release or long-acting opioids for acute pain. And we'll talk about why, more specifically why you wouldn't want to do that. Follow up and reevaluate risk of harm, reduce dose or taper, and discontinue if needed. So again, ideally, particularly when for the conditions that we particularly manage, if somebody is in that much pain that they need an opioid analgesic, and probably the most common reason why, I would probably just say, from observing in my own perspective in sports medicine, typically this is going to be given to somebody who, they have so much pain that, say, it disturbs their sleep. Now, obviously, as we talked about in this class, from a clinical evaluation standpoint, if somebody has night pain, that's something that we need to further look into, just to make sure that there's no other cause or some, really kind of ominous thing that could be causing that. But once that's kind of ruled out, we know that it's just, structurally, for whatever reason, they're having a lot of night pain, it's disturbing their sleep. That's usually where something like this that's just one example where something like this could come in. But again, the idea there isn't to continually, prescribe. In order to do that, we eventually obviously want the individual, particularly in that particular perspective, to eventually discontinue their use. So looking at therapeutic effects, again, obviously here the therapeutic objective is to eliminate or reduce pain. However, with these drugs, and it's not uncommon with these, the sort of side effects, if you will, are very prevalent. Patients may feel analgesia, euphoria, or drowsiness. Not uncommon to have that, and that's part of the reason why, I brought up on the previous slide, just sort of like, again, part of one of the things that these will be for people that just have so much pain that they have trouble sleeping at night. And that's one of the reasons why. However, that also means that, again, there are some things that really need to be taken into consideration when these drugs are prescribed to somebody. People should not lose consciousness or motor coordination. So again, with normal use, it shouldn't go to that point. Obviously, there's always the concern of overdose, so that's why it's really important to make sure that individuals know to, kind of how to manage that. And again, severe adverse effects, sedation and respiratory depression are things that, need to be a concern when individuals are taking opioids. So again, we're looking for relief from sharp, dull, piercing pain. Particularly the type of pain that really sort of, again, really affects quality of life. Again, individuals may, have trouble sleeping. Severe pain associated with, like, say, something like a bone fracture, or like a lot of times, the book gives the example of, kidney stones. Those are obviously very painful. It's not an orthopedic condition, but those are examples where some of this will be given. Again, if an analgesic dose of an opioid medication is administered to a patient that does not have pain, so healthy people who take without pain who take opioids, many times will report the drug experience to be unpleasant. Drowsiness, apathy, reduced physical activity, and then obviously with increased dosages, much like we had talked about, previously, the respiratory depression and fatal overdose does get to be much more of a problem. So looking at the mechanism of action and route of administration, so opioid receptors, they're primarily in the CNS, but you also have a lot of you have opioid receptors elsewhere. So there's the peripheral nervous system and GI tract. We'll talk about how opioids can have potentially affect the gastrointestinal tract. The most common receptor that opioids bind to are the mu receptors. So mu receptors are the major opioid receptors. A lot of your very common opioids are binding to mu receptors. So here we talk about morphine and heroin. Obviously, there's no medical use of heroin. However, it is still an opioid, so we're talking about it here. They are your very common opioids that you would see. Morphine probably being one of the more common ones you'll hear medically getting used. So the other point with mu receptors is they also produce some of those other effects associated with, so beyond the pain relieving effects, they tend to be responsible for producing the euphoria and sedation that a lot of people experience. And that's also part of what affects or is responsible for a lot of the addictive qualities related to these. So it's those effects that, while they help with reducing pain, also can potentially contribute to the addictive nature of a lot of these particular drugs. So the route of the opioid is going to be patient specific. Obviously, the most common that you're going to see is going to be the oral route. So again, analgesia at about 45 minutes and peak at 1 to 2 hours post administration. So those are going to be, and again, that's going to be your most common route. However, IV or alternative routes are also considered if the patient is unable to take oral prescription medicine. So again, IVs can be used for this. There's also so the other alternative routes, you can also have intranasal opioids, subcutaneous injection, intraspinal. So you could either have an epidural injection or intrathecal, and there's also intramuscular options. So if for some reason the oral route isn't indicated or the person cannot take an oral medication, there are other alternatives to that. So here is just a picture. If you looking here, so there's your opioid agonist ligands binding with a mu receptor on the postsynaptic neuron. So again, these are going to be working at the nervous system, so both the central and peripheral nervous system. If you're looking at this picture here, so again, here's the opioid agonist ligands. So ligands are just molecules that connect. To other molecules, and then here's it kind of coming into the mu opioid receptor. Here's the postsynaptic neuron. So obviously here is going to be where your again your pain relief, but it's also going to again be responsible for the sedation and euphoric effects that individuals experience when they take an opioid. Pharmacodynamics and pharmacokinetics of opioids. So we're going to kind of be discussing here are kind of the general qualities of the opioids that we deal with in sports medicine. Again, we'll kind of point out some differences along the way. So we're going to be kind of like specifically mentioning certain types of opioids kind of along the way. So there may be some differences from this, but this is kind of classically what you'll see in a lot of the opioids used in the sports medicine setting. So again, common pharmacokinetics regardless of their form. So most are going to be absorbed very well. Many times oral doses are going to be a little bit larger than parenteral doses due to the first pass metabolism. And we've talked about this with other types of drugs that are absorbed via the enteral route, that they're subject to first pass metabolism. So again, the actual dose is going to be larger versus if we were to if somehow a patient was to be administered an opioid outside of the gastrointestinal tract. So here's some examples here: codeine and oxycodone. So again, it's going to be really important to kind of recognize things about certain drugs. So, and again, some of the more common ones we're going to be talking about. So as you see kind of names pop up, and again, as I refer to tables, make sure you're familiarizing yourself with them. So codeine and oxycodone have reduced first pass metabolism for greater effectivity. So again, that could be a factor in as far as their dosing and how they specifically get used. Distribution. So opioid molecules bind to plasma, then that kind of circulates throughout the body. Once the drug has kind of left the circulatory system, the molecules tend to concentrate very densely in highly perfused tissues. So, highly perfused tissues, thinking the brain, liver, lungs, kidneys. So they do tend to concentrate most in there. They will also accumulate in adipose tissue and muscle tissue if a particular drug is frequently administered. So the drug concentrations in skeletal tissue may be lower, but the tissue itself serves as kind of a main reservoir just because of the bulk of it. So even though, in general, concentrations in muscle may tend to be lower, just because muscle constitutes a good portion of our bodies. It does serve as kind of an area where it goes to. Even though blood flow to fatty tissue is lower, it does tend to accumulate in adipose tissue. Again, particularly if given in high doses, or in the case of, say, like a continuous infusion of opioids that are slowly metabolized. So sometimes it will depend on the opioid, but you can get accumulation in the adipose tissue as well. Metabolism, there is an extensive first pass effect in the liver many times with this. So again, that cytochrome P450 enzyme facilitates a lot of those metabolic reactions. Most opioids are lipophilic, so that means they'll cross cell membranes. Remember, we had talked about drugs that are lipophilic do cross cell membranes very easily. And again, the purpose of that is so that, particularly at the nervous system, it could cross those cell membranes and be able to produce their effects. The excretion is going to be primarily through the urine. So again, we're looking at the kidney. So again, kind of very classic pharmacokinetic concepts here regarding the opioids. Much of what we discussed, so remember we talked about in the previous chapter on pharmacokinetics, absorption, distribution, metabolism, excretion, and this will be something that we talk about with all the different types of drugs that we discuss. Again, is going to be elimination through the kidneys. There should be concern, though, if a person does have an issue or health-related condition to their kidneys. You have to be, again, and the prescriber will be aware of this or should be aware of it. Any drug that is prescribed to them, it will take careful consideration. So the reason why is even many times, small amounts of unchanged drug may even be found in the urine in individuals. So that basically means that, again, the kidneys do have to work very hard in excreting this. So if somebody does have a renal insufficiency, again, it won't necessarily preclude them from getting an opioid, but it may affect the dosage or how high of a potency an individual gets prescribed in that situation. When it comes to dosing, so again, we're going to look at individual patient, as you would with any type of medication. One of the things you're going to factor in is individual patient factors. So for instance, on the previous slide, I discussed how if somebody, for instance, has a health condition regarding their kidneys, for instance, where excreting the drug is going to be very stressful on the kidneys, that may give a provider a sense that they're going to have to prescribe something that is going to kind of minimize any stress on the kidneys. So they may look at like a lower dose, lower potency type of opioid. Same thing if there was like like liver dysfunction, because obviously, again, through from the metabolism aspect, the liver is going to have a harder time metabolizing a stronger opioid. Beyond that, one of the other things regarding dosing and whether a provider is going to prescribe an opioid is the World Health Organization has what's called a pain relief ladder. And what it essentially is it tells medical providers, based on the type of pain the person's having, what type of intervention should take place first. In other words, we don't just give an opioid medication for just a person who has pain. In many instances as well, as we had discussed previously, many times an opioid is only going to be prescribed when other things haven't worked. Now, again, in severe circumstances where there's surgical pain or something like that, that's where that could be different. But, again, we look to our physical agents, our modalities, and, over-the-counter or prescription non-opioid preparations first. So, and then, regardless whether you're starting with that or a low potency opioid, either way, weaker meds can always be replaced by stronger as needed. So don't go with the strongest possible medication first. That's what you would want to do. Now, obviously, they can be an early option for severe pain. It's not uncommon for individuals. Again, I had mentioned surgical pain. Obviously, the pain associated with that would be much more than like even many acute injuries that you would have. Another thing that could sometimes, and we'll talk about combination therapies later on, antidepressants many times can be used as adjuncts for the treatment of neuropathic pain, because again, some of that chronic neuropathic pain can kind of really be problematic, and sometimes antidepressants can be used as an adjunct with that. However, it is important to note that antidepressants may also can potentially have other side effects as well. So that's something that can be considered as well. And again, antidepressants, because they have specific effects on the nervous system, could kind of enhance some of the analgesic effects that many times opioids will give. Again, starting dose can be titrated up or down, and again, many times it can be based on the pain or the side effects. So if the pain does tend to get better, then they may need to go to even like an as needed use of the opioid. So in other words, someone may be prescribed it with a certain frequency. They may be able to reduce the frequency or possibly even reduce the dosage. There is a wide range of concentrations in the plasma for analgesia, so that has to be noted when you're kind of looking at how this is getting used for the individual patient. And again, patients with high pain tolerance, they can be transitioned to NSAIDs many times in the cases of surgery. So we talk about how, surgical pain, sometimes is usually where many times, I guess in our particular sports medicine settings, that's usually where opioids are going to be used. If the patient does have a high pain tolerance, they will look to transition the patient to just, for instance, an NSAID, non-steroidal anti-inflammatory drug to help relieve their pain from the surgery once if the opioid analgesic isn't needed. One important aspect that we really have to be aware of, and this has actually become a bigger thing in recent time, even more so because of the some would argue potentially even the overprescription of opioids, is when we look at opioid addiction. And as a sports medicine professional, this is going to be something just to kind of be on the lookout for. So the next couple slides, we're going to be looking at the characteristics of opioid addiction. So, if we look at some of these various signs and symptoms of this, really important to be able to recognize. As far as opioid use disorder, the actual diagnosis of it is going to require at least 2 of the 11 criteria present over a 1-year time. So that's kind of one important aspect to look at. So 2 of the 11 have to be present over a 1-year period of time. So, again, just being on the lookout for these would be important. And if you kind of understand some of the side effects and things like that, and how opioids work, some of these will make a little bit more sense, the connection between them versus others. So, as I always say, anytime there's like a long list of kind of things to remember, think of the ones that, kind of like make the more obvious ones, or what would at least maybe be a little bit more obvious to you, easier to remember, and then just kind of fill in the blank with the others, okay? So obviously an inability to control opioid use, uncontrollable cravings, drowsiness, change in sleep habits, weight loss, flu-like symptoms, okay? So here's your, some symptoms, some different characteristics here. So here you would have, again, obviously, like for instance, drowsiness. Drowsiness would probably be a pretty obvious one for most people, because of the fact we know just as a side effect, opioids do tend to cause drowsiness. Is part of the reason why people tend to take them at night. Obviously, an inability to control use would be present kind of in almost any sort of addiction circumstance. Now, again, some of the other ones might not be quite as obvious, but again, remember the ones that seem to be a little, make the ones that are a little bit more obvious, and then, like I said, kind of fill in with the others. So continuing on with the characteristics of opioid addiction, so decreased libido, lack of hygiene, changes in exercise habits, isolation from family and friends, stealing from family, friends, or business, new financial difficulty. So as I, again, just trying to make some connections with some of this, because I know sometimes, when you're trying to remember lists of things, it can be difficult. If you think of a lot of just addiction issues in general, so I think all of us are aware of, like, kind of general things you tend to see in individuals who have, substance abuse or addiction problems, like the financial difficulties. Obviously, people spending, they're trying to find ways at some point to get more of the drugs, so they're, obviously sometimes in unlawful ways and spending, large amounts of money in order to get that. The social issues that come about a lot of times with addiction issues, because as people start to notice changes in behaviors, they kind of start calling it out, and then the individuals who have the addiction issues will tend to have problems with that, and then start to sort of isolate themselves from family and friends. So that becomes something associated with that. And then, like for instance, like a lack of hygiene, it's not uncommon for people to start to not take care of themselves as well, because the addiction kind of takes over their life. So again, making sure to kind of remember, these things, because again, this will be kind of a part of a big issue as it relates to being able to, again, manage the overall welfare of our patients. Combination therapy is something that is very useful as well, sometimes with opioids. So sometimes combining an opioid with a different drug is useful. Now, in general, using drugs that have the same actions typically not warranted. However, certain opioid combinations could sometimes be useful. In other words, sometimes if you're trying to basically, if you have someone in a chronic pain state and they just kind of need to break through it, sometimes a patient might get, for instance, like a slow release morphine just to start, and the acute might be managed with a more rapid onset formulation. So there you might have a combination of putting in like a more slower releasing with a rapid releasing, just to kind of help with the overall pain. Again, you could also combine opioids with like a different type of drug. So in other words, for instance, you may combine an opioid with, say, like acetaminophen, or maybe a non-steroidal anti-inflammatory drug. Sometimes antidepressants many times could also sometimes help with pain as well, and sometimes they'll combine an antidepressant for in combination with an opioid to assist with pain relief. So here's some, combination of analgesics, opioids, and NSAIDs that are commonly prescribed in sports medicine. So it's important to note that if they have a star next to them, that is a medication that's banned for international competition. Okay, and we'll kind of talk about some of the things that go along with that. So Dilaudid, for instance, would be one of those medications. But you could kind of see here some of the different the different types of opioids and some of the combination opioids. So, for instance, we had talked about in combination therapy, if you look, here we have Tylenol with codeine, okay, for instance. So there you're getting the added benefit of the pain relief mechanism that you get with acetaminophen in addition to codeine. So that would be something. Percocet is oxycodone and acetaminophen. So some different examples here. Again, as you kind of go along, so a lot of times I would always say this in pharmacology class, and I'm sure I've probably even said this in other videos. There is something to a name. So I know, again, there's a lot of different names. There's a ton of different medications. But, as you kind of go along, pay attention to the name of a lot of medications. So many times that does sort of help with the process. Again, not in all circumstances, but that could certainly be something that, could kind of help you remember some things as we kind of go through different types of medications. So indications and precautions. So again, opioids are often used, they call it the second step of the World Health Organization pain ladder in the management of acute and at times chronic pain. It may be effective as a treatment option for chronic non-cancer pain. So there's a lot of different things because of what these medications kind of bring with them and how we have to kind of monitor them. The prescription is going to be based on a couple things: is the patient acceptance and side effect profiles. So if a patient is going to be given an opioid, it's very important to talk about some of the more significant side effects that could occur. We're actually going to spend some time talking about what's called opioid-induced constipation, which is a pretty significant thing and many times causes a lot of problems for people. But many times a physician, in kind of deciding to use an opioid, will discuss different types that are indicated and kind of go over the kind of the pluses and minuses of each of them. But looking at kind of like the pharmacodynamics and pharmacokinetics will be important in that decision making process. So and looking at side effect profiles. So that'll be something that is considered. Again, we're talking kind of a different level of pain control. That's obviously where this would definitely be indicated. So one of the more significant side effects associated with opioid use is opioid-induced constipation. So again, opioid-induced constipation, so you have a reduction in spontaneous bowel movements after starting opioid therapy. So basically, what you end up here is no fewer than 3 bowel movements per week. And it generally, the part of the issue associated with this is it generally doesn't respond well to over-the-counter laxatives. So, typically over-the-counter laxatives would work for most cases of constipation. Opioid-induced constipation doesn't seem to work well with this. So one of the things that is very important, and we talked about, like in sort of the provider counseling the patient on opioid use, really important proper intake of fluid and fibers. And sometimes they still will just even give like either a stool softener or a laxative, or suggest those. However, if the person does get far along with this, the over-the-counter laxatives tend not to work well. So many times, what'll be given or prescribed for the patient, what's called the peripheral acting mu opioid receptor agonist, and this is going to be used to help reverse the constipation from opioids. So if somebody really starts to have a problem, again, there should be follow-up, or the patient should kind of be counseled and told when to consider possibly having to take one of these. Again, make sure to use the medications per dose as prescribed, and you'll cease opioid use when this ends. The book does give some examples of these, so you might want to include those in your notes as well. So if you've gone through your reading, look at the types of peripheral acting mu opioid receptor agonists that they talk about. They are contraindicated though if someone has a GI tract obstruction or liver impairment. So in those cases, these types of drugs would not be utilized. So other adverse effects. So I would say when we're just kind of looking, at the different systems of the body, again, probably the two biggest systems that tend to get affected the most from the standpoint of an adverse effect are probably your central nervous system and gastrointestinal tract. So you'll probably notice a lot of the things associated with opioids tend to particularly involve those two systems. So common side effects, again, a lot of, again, CNS, gastrointestinal tract. So mood changes, sedation, respiratory depression, decreased peristalsis, which is just movement, gastrointestinal motility, and then plus a couple others that are associated with that tend to be associated with those particular systems. Um, Again, nausea and vomiting secondary to stimulation of the chemoreceptor trigger zone tends to be something that tends to occur as well. You do tend to see this particular effect many times if when someone first starts get initiated with morphine. So morphine tends to be one that tends to do that. Increased doses of opioids tends to lower the CO2 the response. So our normal respiratory response to carbon dioxide can get suppressed, and that could lead to the whole respiratory depression. So that is always a concern as well. Um, so an opioid plus a CNS depressant, there could be a potential decrease in respiration, which could be fatal. So it's really important that opioid analgesics, for instance, you really caution individuals regarding alcohol use. So if someone is taking an opioid, they should avoid alcohol because again, alcohol is another depressant. So you could get that combination effect of taking an opioid with that CNS depressant could create more issues. So, so make sure that anytime any CNS depressant, there'd be other ones outside of opioids, but anytime someone is given that, the combination with alcohol, could potentially cause a decrease in the respiratory response. So looking at the warnings associated with opioids, and again, these are things that will get discussed quite a bit because these are, again, when considering to use an opioid, there's always a lot of things that have to be taken into consideration, some of which we've talked about already. As we discussed, there's been kind of just a problem in general in more recent times with the abuse and overuse of opioids. So many times, being potentially overprescribed, misused, and the association with the addiction has been pretty bad with these. So again, these are medications that are among drug classes that definitely have a heightened risk of causing significant harm when used in error. So again, there's some drugs that maybe don't have as much of a risk with many problems, but opioids are certainly one of them. And as we've talked about the black box warnings, well, pretty much all opioid medications have black box warnings because of the potential for abuse amongst people who get prescribed opioids. So the FDA has general guidelines for opioid use. Some of this was discussed. So non-opioids, basically ineffective, inadequate, or not tolerated. So if we give our other pain medications for some reason, they are either not working, a patient can't use them because of some other reason, then that would be an indication for opioid use. Okay, so really important, and the FDA really encourages this, that providers have to balance the patient experience plus risk factors. So that the risk factors obviously associated with them needs to be considered. So the three primary FDA opioid warnings, obviously risk of addiction, abuse, and misuse. Again, each patient's risk has to be assessed before prescribing these drugs. And again, they should be monitored. So I think some of what potentially has happened in recent times is, a patient has pain, a physician gives them an opioid, and then there's no follow-up. So in many instances, there should be follow-up, make sure that it's, the patient's function, and when an individual is coming, back to full function and having decrease in pain, then either the dosage should be reduced and or they should be starting to be taking off the drug. The risk of respiratory depression, which we've already talked about, Again, you have to be aware of that, and especially during the initiation of the drug, or if the drug dose has to be increased. So those would be two circumstances where that really has to be watched. And we already talked about the combination use with other CNS depressants. So, combining opioids with, say, benzodiazepines, which are very commonly prescribed as well, other CNS depressants like alcohol. Pretty much a patient, if they are on an opioid, should be counseled not to consume alcohol because of the potential respiratory depression that can occur with that. So again, patients should be monitored again for things over the use of time. And one thing to note that, prescription of less than 5 days does reduce the risk of misuse. And again, for most patients, particularly in a sports medicine setting, now, other patient populations, there's certainly instances where longer prescription times may be warranted. But many times in sports medicine settings, it's going to be typically pretty short. So, and in most of those cases, the risk of misuse is certainly minimal. However, again, don't be kind of, in a false sense of security with that, because abuse can really happen at any time. We just know that typically with shorter time frame periods of using it, it does tend to the potential for misuse is lessened in cases where you have shorter times of being treated. So now that kind of takes us to our classes of opioid analgesics. So again, this is kind of an important thing to kind of note the different kind of levels, because again, some are a little lower potency, some are a little higher potency. So again, and we're going to, the book discusses, and we'll discuss here some of the more common opioids that athletic trainers will encounter when kind of providing care to, again, our physically active population. So again, pay attention to the tables in the books in conjunction with what I'm discussing here, because that could be kind of helpful in remembering these. Again, kind of following the World Health Organization pain ladder, which is basically kind of, I guess, almost like an algorithm of sorts, saying like, basically it's the World Health Organization's suggestions as to how and when opioid analgesics should be used and what type. So we're going to start with the lower potency opioid analgesics. Some of the more lower potency opioid analgesics like codeine, and then followed by more of your medium potency opioids like morphine. Okay, and typically what they'll do is they'll compare the opioid for the kind of coming up with the classes of opioids to kind of compare everything with morphine as far as therapeutic equivalence. So again, opioids, except for codeine, because codeine is really low potency, they're going to compare to morphine for that therapeutic equivalence. So, low potency codeine is often combined with acetaminophen. So again, this is one, typically one that can be used to treat very mild to moderate pain. Which again, many times you'll see, obviously, like in our settings, and they'll combine that with acetaminophen. So again, this is a mu receptor agonist. It's going to inhibit the pain pathway and kind of alter the perception of pain. And the other thing, codeine, so an important thing to note is that, so codeine is also very common in another type of medication. It's very common as an antitussive or something to help reduce cough. So an individual who who has a persistent cough from, say, like a cold, who's looking to have a cough suppressant, maybe some over-the-counter cough suppressants aren't working, and the cough is becoming a problem. Many times a physician will prescribe an antitussive, which is to help reduce cough, and that's present as well. It's also sometimes used as antidiarrheal for antidiarrheal effects, which makes sense because we talked about how opioid analgesics cause constipation. So, and because codeine is very low potency, it can be used for that particular purpose. So continuing on with the classes of opioid analgesics, so you go to your medium potency. So we're looking at morphine and its derivatives for this particular class. Again, these are the most widely used opioids other than anesthesia or for procedural sedation. So oxycodone would be within this classification. This is for more moderate to severe pain, and this is available for immediate release, which again, so you want your more immediate release in the cases of more like acute type pain. Hydrocodone, it's equipotent to oxycodone with a onset of 10 to 30 minutes and a half-life of 4 hours. So here we have this, and again, so look at all the pharmacokinetics and pharmacodynamics in the tables that you have, kind of given all of the different levels, different potencies of drugs throughout the chapter. And then we get into high potency. Fentanyl has become talked about a lot in the media. This has been something that has been abused and caused many deaths. It's 100 times more potent than morphine. Time to peak analgesia. So here you see approximately 5 minutes. So within 5 minutes, somebody can have analgesia from fentanyl. So again, this is more widely used in intraoperative and periprocedural analgesia. So this is a very strong medication. However, and again, as you've probably heard of this in the media, for a lot of the deaths and major issues kind of surrounding inappropriate use of opioids. So again, just kind of looking at fentanyl, because we're going to spend some time talking about this. So fentanyl is a synthetic opioid, and it's used for very severe pain. It's actually, again, it's almost 100 times more potent than morphine. And we've kind of talked about some of the things associated with fentanyl, but again, it does have obviously medical use. So it is intended for acute, but is used for chronic pain that is more widespread. So it can be used in the case of chronic pain. It's poorly absorbed by the GI tract. So typically, the way it's going to be administered is through a buccal tablet, nasal spray, or through lozenges. A transdermal patch could potentially be applied as well. They give an example of that in the book. And that could provide, 48 to 72 hours of analgesia. So it's really important, and another thing that has become common to discuss is the use of opioid antagonists, in particular naloxone, or you've probably also heard of Narcan. This is really important in the case that somebody does overdose on an opioid, and in particular fentanyl. And again, this is intended for the emergency treatment of opioid overdose. You use this for about 2 to 3 minutes until emergency personnel arrives. So here's a picture from your book. Your book also shows Narcan. So Narcan is given as a nasal spray. That's probably the more common one you can get. You can actually buy Narcan in a drugstore to have, just in case as an emergency medication. It can also be administered intramuscularly, so that's important to note as well. And again, so this is to reverse the toxic effects of opioids. So here we're kind of showing how it works. So here's your opioid receptor on the brain. Here's your opioid. So in the case of an overdose, basically naloxone or Narcan basically serves as an antagonist, and kind of binds there to prevent and kind of knocks the free receptors, knocks the opioid out of the free receptor. Again, it should be basically used every 2 to 3 minutes while waiting for emergency personnel. So if ever you encounter a situation where someone is potentially suffering from an overdose, Narcan could be administered. You're basically going to use it every 2 to 3 minutes while waiting for emergency personnel. So a person still does, even if it seems like they're doing better after administering it, they still have to go to a hospital. So anytime naloxone is administered, they need to immediately be transported to a hospital for further emergency care. So in summary, again, are very effective medications. Again, the biggest concerns are the issues regarding addiction to these particular drugs. So again, with responsible use, they have indications. Again, typically in sports medicine settings, they're not going to be used long to the point where abuse could be a problem. However, you do have to consider things like, again, an individual potentially combining it with alcohol and things of that nature. So it's always something that needs to be concerned about. So again, understand warnings and signs of abuse and misuse, and we should be proficient in the use of naloxone. So again, being familiar with this particular medication and how it gets administered. Again, you could see, note the picture in the textbook of what it looks like. Again, it's basically, from our standpoint, we can use it as a nasal spray. There are intramuscular injections as well, but the nasal spray works really well and can kind of be administered in emergency situations. Again, really important to understand that those individuals still need further treatment. And your objectives. So again, this serves as a summary. So again, differentiate between endogenous and exogenous opioids, the various routes of administration. Make sure you know all your classes. So you should be familiar with all the classes of opioids. Again, go through, look at the low potency, medium potency, high potency, some of the examples of each of those, really important. Again, obviously we had spent a good amount of time on opioid misuse, abuse, and overdose. And again, being familiar with emergency Narcan spray in the case of suspected overdose.